So let's talk about active surveillance first. Active surveillance means that we know that the patient has cancer and we are going to just surveillance this patient without surgery to see if this cancer grows or not. Most of thyroid cancer patients with a small cancer less than 2 centimeters can be monitored without surgical intervention because most of these will not spread. Obviously, there are certain specific criteria, making sure that there are no metastatic lymph nodes. This is not close to the capsule, not going to cause extrathyroidal extension or higher risk of spread, etc. So if we have all the features with active surveillance, these patients can be monitored without any surgical intervention. But if you think about it, still there is a good number of these patients, it depends on their features, can progress and can eventually spread to lymph nodes, etc. But if these patients can, and instead of just doing nothing and just watching it, if we intervene with a safe intervention, like in this case, radiofrequency ablation, we can go in and burn it and make it disappear, not just to keep the cancer inside and hope that nothing will happen. So, and you know, a good number of our patients that we treated, they were already on active surveillance protocol, and then they decided to switch to this. It just makes them feel better, sleep better at night. I mean, it feels better that the cancer inside you is gone or shrunk significantly, better than say, oh, the cancer is still the same or it's not growing as much. So I think it's definitely, in my mind, a great alternative to active surveillance. And the other thing about the ablation and small cancers, that I tell this to patients, and my own experience, and we're trying to eventually publish on this, that the very small number, and this is like I'm talking a small number of patients that did not respond well to the ablations, they tend to be actually aggressive cancers with bad mutations, aggressive mutations that tend to eventually have a higher chance of metastasis. So I tell patients the ablation can be used as a treatment modality, but also as a prognostic modality. What does that mean? A treatment modality that we can shrink it, we can make it disappear, we can make it go away, etc. But if it doesn't really respond, this means that you need to be aggressive with treating this patient. And maybe instead of just taking the lobe for that small cancer, you need to actually, these patients might need to take the entire lobe. So in every single case that did not respond well to the ablation, that was really an alarm that this is a bad cancer, and a lobectomy was not sufficient. These patients required the removal of the entire gland and required radioiodine therapy afterwards because the cancer is aggressive. And that's why for cancer patients, I prefer to do genetic testing to understand as much as possible about these, as much as we can prior to the ablation and prior to using this as an alternative options. But definitely now we have a very safe alternative treatment option and also prognostic modality compared to just active surveillance watching cancer.